مساء الخير. انا هقول الحبه دول كده بالعربي ان انا همشي في الكيسز كاني انا في السيشن نفسها في الورك فلو بتاعت السكريننج ماموجرام. البيشنت she doesn't aware she's having a lesion وانا كمان مش عارفه وانا مش في ورك شوب، فبالتالي انا مش من الاول ماسكه التول بتاعت العدسه وماشيه بدور اكتوال كالسيفيكيشن، لا انا في الورك فلو ببص على الحالات بسرعه وحالات كتير واكزهوستد ممكن ساعات كتير. فالدنيا كانت ماشيه ازاي وانا ببص انا والاي اي. First I will go with the AI. I'll go about the microcalcification. I'll say that the AI we use, which is Lunit, provides what's called the pixel level abnormality scores as heat map, where the calcification is spotted in the form of low to high probability of breast cancer according to the intensity of the color is. And then after location of the site of the calcification, there is a representative score of about the maximum of the pixel level abnormality scoring, which is it's a reflect of the degree of confidence for the suspicion of malignancy, ranging from the then 10% to 100% for the highly suspicion of malignancy. And then we have the probability of having a cancer on the left side because I have a percentage of 96% present at the bottom of the image. And for the right ones, it give it a less than 10%, which means it's probably non-cancer. The first case, it's 58 years old, female. At the first glance, can you see the grouped calcification? For me, yes, the calcification is obvious in the right breast upper outer quadrant. It's seen in the CCN MLO having the same orientation and distribution. For me, it's the BI-RADS 4. The AI also is coinciding with me. It gives a scoring of a 98%, probably a cancer. And then when we do the stereotactic biopsy targeting this calcification, the pathology was by the wire localization and excision. It's ductal carcinoma in situ, intermediate grade, with some fibroadenosis and a typical ductal hyperplasia. In this case, the eye helped in the detection, so I'm confirmed about the site of the calcification, in the diagnosis, in the distribution as well. I can easily target the extent of the calcification. Case 2, it's 63 years old female. In the year 2022, with the first presentation for us, actually we are targeting the calcification, and in this case, yes, I can see the calcification in the right breast lower inner quadrant. For me, at this time of presentation, the BI-RADS was BI-RADS 3. The calcification is a little bit macro with lucent center, although it is clustered. For the AI, it gives it a probability of possibly cancer. It's a 67%. I get into the year earlier for the comparison when I find the calcification and the patient is coming usually for annual follow-up and the calcification looks benign, we'll do the follow-up. And so I targeted her earlier mammogram in year 2021, and I found that the AI gives it a scoring of 66%, which is possibly cancer. So the scoring was 56%, and then at this year it was 67%, although I find it looks benign, but I a little bit considered the AI for the higher scoring that he gave to me. And I do a tomosynthesis. I proceed for the other modality. Yes, the calcification looks benign with also some lucent center, but I'm having increased density and distortion added to this area. It's obvious here that I'm having this increased density and some distortion. I went to the ultrasound. I found no, this area of increased density, it is a cluster cyst. I still go with the benign condition, but I would like to add to the knowledge of the AI that I'm having increased percentages about 10%, and I went although it's Barrett 3, I give it a follow-up in 6 months duration with the mammogram. Then when I did the follow-up in the next year, in 2023, after 6 months, still for me, it's Barrett 3. It's more denser and the calcification more clustered and more increased, and some of them are different sizes. And when I went to the AI, I found that the scoring is higher this year. It's about 95%. And so there is increased scoring, 56%, then comes to 67%, and then 95%. And this time in the ultrasound, the cluster cysts have been collapsed, and I'm having replaced by soft tissue present at the area of the cluster calcification. So the Barrett's, according to the ultrasound, this year it's in the next year, it's 2023, it's Barrett's 4. I targeted. And it was intraductal papillomatosis with fluoroid atypical ductal hyperplasia and focal atypical ductal hyperplasia, yet with 2% cribriform ductal carcinoma in situ. So although it's to my side, it looked benign calcification, grouped benign calcification, but the AI, when raised the suspicion of malignancy by increasing the scoring through the years, have the chance for the patient to get the excision, and we detected only 2% ductal carcinoma in situ within this benign pathology. So I help it in the detection, in diagnosis, in the distribution, in the follow-up. In detection, no, because I saw the calcification from the start and I could target it and follow up. But actually, it helped me in the diagnosis by raising the possibility of having a cancer and pushed me for the excision, in the distribution of this lesion, and for the follow-up. As you can see, it's very impressive to have these 4 images collectively finding these percentages scoring precisely illustrated on the cases, and instead of having the zoom and to magnifying glass to go through the calcification and get the different images and see them and put them together, no, the AI gives me the scoring, the extension, and how the progress of the disease is. Case number 3, this is the dream of any radiologist, the fatty breast. Definitely about that there is no lesion in the breast, that the patient could go for the annual follow-up very easily at 6 years of age. That could be AVS listed. So here, can I see the grouped calcification? In this case, first site, no. I go to the AI, I found that there is a lesion in the upper outer quadrant of the right breast with a high probability of being a cancer, is 92%. Then I get the Dooming magnifying glass because he helped me precisely. I'll go to the area that he targeted. I found this cluster of microcalcification, and it seems that it is tracing a lesion. It's circumferentially surrounding something within. So yes, AI helped me this time to target the calcification in the right upper outer quadrant. I could give it a 3 because the one traced, the lesion is traced, is loosened. So I may think of a fat necrosis or some cyst with cluster calcification around it because its calcification are more or less punctured and the lesion within is loosened. I went to the ultrasound and I found, no, it's a speculated lesion with a vertical orientation. Not typical malignancy for me on the ultrasound, and was easily targeted by the AI and give a precise percentage. So it's by RATS 4 when I get to the ultrasound, and the pathology was invasive ductal carcinoma grade 2. So in this case, the AI helped definitely in the detection this time, in spite of the breast is fatty, in the diagnosis, in the distribution, of course. Case number 4, this case is 40 years old of age, and I could from the first sight find there is a symmetry in the right breast, which is taking the upper quadrant, and if I can see the calcification within this asymmetry for the first sight, no, it's very difficult. And the AI, he telling me, no, there is an area, it's about the upper outer quadrant, it's about 98% probability of being a cancer. I go for my magnifying glass and display the contrast, and I found these calcifications, which is different centers. It's not actually relating to the density. It's, some of them is in the fat as well. So I can see the calcification targeted by the AI. It's by RADS4, and the contrast enhanced mammogram, it has traced the same distribution that was demonstrated by the AI as well. In this time, it's by RADS4, definitely by the contrast. It was an invasive ductal carcinoma grade 2 with peritumoral lymphovascular invasion, low and intermediate ductal carcinoma in situ, solid and crepiform, and commido necrosis. So we have the precise distribution of the calcification as well. Sometimes we find the group calcification which is separated with fat or with apparently normal tissues, and I don't know if it is related to the same disease or not, but the AI, when through tracing the targeting of the AI, I could easily confident about it that it's telling me the size. And when I go to the contrast enhanced mammogram, I found that the contrast mammogram, the pathology, and the AI market the treble modalities giving me the same extension of the disease. In this case, it was the detection, the diagnosis, the distribution as well. In case number 5, it's 40 years old female. Can I see the grouped calcification? This time, no. I could at the first sight find where the calcification, but the AI gives me the highest scoring in the upper outer quadrant of the left breast. When the calcification comes to the area of density, it's difficult to detect it from the glandular tissue overlapping. I go to the magnifying, and I couldn't still see it probably. Then by enhancing the contrast of the image, yes, I can see this calcification tracing the glandular tissue. It is the boundary calcification. And for my BI-RADS is BI-RADS3. It goes with the fibroadenosis and fibrocystic changes. On the ultrasound, I could find some clustered foci, and so I raised the suspicion a little bit and give it the BI-RADS4, because also I have superimposed my impression that maybe I'm dealing with a suspicious calcification. On the pathology, it was only fibrocystic mathopathy and apocrine metaplasia calcification with no evidence of atypia. In this case, the AI helped, yes, in the detection. But for the diagnosis, no, it wasn't. My diagnosis was the one appropriate. And for the distribution, yes. But at least I can do the follow-up for the case. Maybe this calcification, it changes in its appearance and distribution, and later on may develop some sort of carcinoma. So thanks for the AI, although it gave me the false diagnosis, but at least it's targeted my impression that I'm dealing with a calcification that should be considered later on. Case number 6 is also predominantly fatty. I'm having only the intramammary lymph node in the upper outer quadrant of the right breast. 53 years old female, and when I come to the post-menopausal period, kindly go through the fatty breast with more meticulous attitude. So this time also, can you see the grouped calcification? No, although it's a fatty breast. Then the AI tells me the elbow and tells me, no, go, this is to the left breast, the lower inner quadrant, there is a lesion, 75% possibly to have a cancer. I change the contrast of the image and go with my magnifying glass, and I spot this calcification with linear distribution, which was so much faint, although it's a fatty parenchyma of the breast. The calcification right now, I guess all of you haven't seen calcification. In this specific case, it was not obvious even on the monitors in the workshop. And for me, actually, the one targeted my eye was the I'm workflow and seeing a lot of cases, found the fatty breast. I'm so content, yes, and no, there is no calcification evident. But with the experience with the AI, even the fatty breast, sometimes I couldn't see the malignant calcification. And when this calcification was targeted by the pathology, it was ductal carcinoma assigned to intermediate papillary type. So definitely the AI helped in the detection, in the diagnosis, in the distribution, definitely because I didn't see the calcification from the start. And if it was a benign condition, could help me also in the follow-up. Case number 7, it's 52 years old female. Can I see the calcification? For the first time, no. Then the AI tells me there is an area here in the lower inner quadrant in the no man's land. It's in the fatty part of the breast. But instead of raising the suspicion this time, he gave it about a probability of 17%. It's probably non-cancer according to the AI prospect. For me, for my experience, there is nothing to exclude when I get to the no man's land. It is the suspicious lesion, although it looks benign. Because the ones with benign and malignancy is the glandular tissue. Anything outside the glandular tissue, unless it is intramammary lymph node, I should consider malignant proven otherwise. So when I found this lesion, the AI gives it only the 17%. I asked to be targeted with a biopsy. It's a little bit distorted and having these 1, 2, 3 puncted calcification, yes, it's not too much, but I couldn't give it the chance for the follow-up, especially if the patient is 50 years of age, it's 52 years of age. For me, it was BI-RADS4 on the imaging, although the AI tells me it's probably non-cancer. When it targeted with the stereotactic biopsy, it was just proliferative fibrocystic disease and usual ductal hyperplasia. Although this pathology is not coinciding with my impression, my experience, but if the patient comes to me, no way to skip the biopsy for a condition of this case, although the AI gives me a low scoring. AI helped in the detection, in the diagnosis, in the distribution. No, it's helped in detection and in distribution, and also the diagnosis, because it's lowered the scoring and tell me, although it looks suspicious for your impression, but for me, it's not malignant. But again, although the AI give it a low scoring, and every time I'll see a lesion in the no man's land, I'll take a biopsy, even if the AI didn't mark it. Case number 8, it's a 53 years old female, and for the first impression, again, due to the glandular pattern of the breast, I didn't see the calcification. The AI spotted in the lower inner quadrant very fast in 1 minute that I'm dealing with a large area in the lower inner quadrant of the right breast with a probability of being a cancer 80%. I get the magnification and find this constellation. It's like the stars, a track of the stars like the Big Bear. And then their clusters is having multi-centers. A mass could be established here in the lower inner quadrant, but there are some clusters scattered with apparently normal tissue in between. For me, of course, it's BI-RADS4, and I am definitely going through with the AI probability of it being a carcinoma. I go to the contrast enhanced mammogram for the distribution. I found only this lesion here in the lower inner quadrant, which was apparent in the mammogram. It didn't give me the whole clusters of the calcification. But still, we're having the category of suspicion, it's BI-RADS4, and in the pathology, it was invasive ductal carcinoma with desmoplastic reaction of the surrounding parenchyma. AI definitely helped in the detection. I only see one lesion, but by the AI, I get all of the centers and all of the extension of the disease. The diagnosis, because it gives me a high probability of being cancer, which is 80%. The distribution, definitely. In case number 9, it's 59 years old. Can you see the calcification this time? Yes, I can see targeted here in the deep central portion of the left breast. And for me, it's definitely suspicious. It's in the no man's land. I'm having different sizes, different shapes, and the linear orientation. It's on year 2021, the AI gives me the probability of 76 to 99% with the percentage of 86%. And then when I go to the mammogram, and I can see that there is a fat dispersing between the calcification and the MLO, the distribution of the calcification was different from that of the CC. So I give it the chance for a 6 months follow-up duration. Then after 6 month duration in the year 2022, I found that the AI that have given me a high scoring in 2021 have reduced the percentage to 50% and tell me the one I was telling you that is probably a cancer No, this year it's probably non-cancer. The fat have dispersed the calcification more due to the physiological changes and the normal pattern of fat replacement of the tissue of the breast. Because if I'm dealing with a cancer, the tissue will be more denser, more compact. The calcification is traced along a soft tissue, so it's highly to probability that the increase of the percentage of the AI. But when the AI gives me a low scoring, this means that this calcification having wide dispersion. But I need to see them in a more magnified view. And for me, although the orientation of the calcification is different, but the age of the patient is high, and the more discrepancy in the shape of the calcium is different. So I asked for the biopsy, and when we took the biopsy, it was fibrocystic changes, fibroadenoid changes with intraductal papillomatosis, atypical ductal hyperplasia, sclerosing adenosis, no malignancy or DCIS. So the AI helped in the detection. No, I can see the calcification. For the diagnosis, for the first time, he was high rating the calcification. For the distribution, yes, he gave me always the distribution. And follow-up, yes, he gave me the impression of the follow-up. Why I'm putting that it helped me in the diagnosis in this case? Because when I did the follow-up, he confirmed the sense within me that probably maybe I'm dealing with benign calcification, although it's present in the no man's land, by the decreasing the percentage in the follow-up session. If everyone wants to stop me with questions during the cases, it's okay. And again, do the impressive image that I get the 4 images view with the percentage showing the raising or the decreasing of the percentage. In case number 10, it's 55 years old patient. Can you see the calcification? For me and the work during the workflow, no. The AI in 1 second told me that there is a lesion in the central portion of the breast and upper outer quadrant. It's about 50%. It's possibly non-cancer according to his calculation. I go for the magnification and I found the calcification and I gave it by RADS4. It's clustered and going with the amorphous appearance. On the ultrasound, it looks suspicious that the lesion is indistinct with the vertical orientation is longer than the horizontal one. Still going with the RADS4. And when I targeted with the stereotypic biopsy, the pathology was just fat necrosis and apparent ductal hyperplasia with no malignancy. So he tells me it's possibly could be non-cancer. Detection, yes, he spotted the calcification, and distribution, always the AI, the one that tells me about the distribution. The next case is 50 years old. This time I can see the calcification. It's in the right breast lower inner quadrant. And I give it the BARA3 because it is spaced and a little bit not microcalcification. The AI tells me it's about 92% suspicious and probably cancer. I'll go with the breast microbubble ultrasound. I can spot the lesion. It's indistinct and echogenic. It could be fat necrosis. So I gave it the BARA3 and lower the staging of the lesion. It was targeted by the stereotactic biopsy. And it was fibrocystic changes, biliary apocrine hyperplasia, and usual ductal hyperplasia with no malignancy. In this case, I can see also the calcification. It's in the upper outer quadrant of the right breast, and the AI gave it a low probability of being a cancer. It's only 11%. For me, it was by RADS4. Actually, it looks suspicious with different sizes, different shapes, and a little bit of polymorphism in the arrangement. On the ultrasound, it's definitely suspicious with the vascularity of the lesion. It's the typical appearance for any radiologist of the DCIS. I gave it a RADS4, and on the pathology, it was invasive ductal carcinoma, although the AI gave it just 11% at its probability, with even a DCIS component. The AI helped in detection, yes, it detected the lesion, but also I can see it this time. For the diagnosis, no, it wasn't. For distribution, yes, it gave me the distribution, but this time the diagnosis failed. This case, it's almost extremely dense breast. It's very dense breast. For the AI, it targeted the calcification, thanks God, because it's going to be hard work in order to target all these glandular tissue and define the calcification, which is buried in depth. It was the probability of 61%, possibly a cancer. I go with the dooming, and I give it the Biobrad 3 because it's spaced and a little bit punctured. I give it the follow-up 6 months duration. And then in the follow-up, I found that the AI have decreased the percentage to 50%. So it was in 2021, 61%. And in 2022, when I give it the follow-up, it's 50%. No need to get the magnifying glass, no need to trace the breast all through to find the calcification. He targeted the same area and decreased the percentage. Thank you, AI. I have saved a lot of time going through the follow-up cases. And detected in the right breast another newly lesion that's in the dense breast, which also will be a very hard work for me to go to all this granular tissue that give it about a possibility of 30% possibly non-cancer. I targeted the right lesion this time. There is also calcification, and I give it also Biobrad 3. And for the left breast, also Biobrad 3, because moreover, the percentage of the AI was decreased. Then I target the one on the left side, because the right side, it looks for me Biobrad 3. I'm going to give it follow-up, but for the left side, I want to target it. It was just fibrocystic changes. So it helped in detection, in diagnosis, in distribution. Yes, in the detection about the right side, in the distribution of both sides. And for the follow-up of the case, I could trace the left side calcification from 61 to 50%, and yes, it was confirmed by the biopsy that I'm dealing with the fibrocystic changes and no malignancy there. Again, the demonstration of the follow-up images, with the right one to include in the follow-up later on. In case 14, the patient had left mastectomy and now is doing her surveillance. Can see the calcification. Yes, it's in the upper outer quadrant of the right breast. It looks suspicious for me, especially if the patient have a cancer on the other side. I have to consider any pathology, even if apparently it's benign looking. The eye tells me you should take a good concern of this lesion. It's about 79% probably being a cancer, targeted with the stereotactic biopsy, the wire localization, excision, and it was intermediate grade ductal carcinoma inside to CRIP4. So I found in this case the detection, the diagnosis, and the distribution. This is the last case, the breast extremely dense. I could find that there is area of asymmetry here in the upper outer quadrant of the right breast and another one in the lower inner quadrant with the calcification very apparently and obvious for me. What about the upper outer quadrant? The calcification is dispersed. I could think of adenosis, but no, the edge of the patient is not coinciding with such appearance of distinction of the calcification. Also with more or less the increased density. But the one suspicious is actually the lower inner quadrant, and that's the one I'm going to target with the biopsy. But for the upper outer quadrant, a little bit, maybe I give it a more or less impression. So I'll go to the AI and see what's going to give me, and it tells me no, the whole breast is involved with this malignant calcification. It involves the whole breast, and the probability of being a cancer is 99%. It's definite that we're dealing with a cancer. The right breast, upper outer, central, middle, and posterior third asymmetry targeted the calcification in the lower inner. It was invasive ductal carcinoma grade 2 associated with cribriform ductal carcinoma in situ of intermediate grade. So I may consider to biopsy the upper part in order to confirm if the AI is telling me the truth about the extension, because the patient will remove her breast. From where I'm going to take the biopsy? It's the whole breast is involved. Maybe I take the biopsy from here in the upper outer quadrant because it's the one proximal to me
for the first vision, the calcification involving the whole breast, the increased density involving the whole breast. So it's the one accessible for me in the outer portion of the breast. But according to the AI and the heat mapping of the AI, actually I should target the areas of the red color, the intense color, the ones with the yellow or the red, in order to get the invasive component of the lesion. Sometimes if they get a biopsy in the light green or the turquoise portion of the lesion, I get the fibrocystic changer, the typical ductal hyperplasia, and I tell myself it's not coinciding with the appearance which you have in the mammogram, and goes to the pathology, and the pathologist said it's okay for us, it's benign for the radiology coloration. And when it comes to the radiologist, he tells me no, still suspicious, I want to redo the biopsy. And sometimes the patient redo the biopsy for 3 times and 4 times, and it's palpable, and the symmetry is palpable for me, and every time it's a benign pathology. But when I go with the heat map, it targets me through the intensity of the color where to put my needle, to be definite about that the upper part of the breast is concerned with the DCIS or not, especially that the DCIS have skipping lesions, what I call the skipping lesion, because if it removed the lower inner quadrant, I could find a free edge around it by the surgeon. I did my job, but actually there are skip lesions that I couldn't confirm. But when I take the biopsy from the areas of intense color map, I could tell him if there is another lesions or not about the imaging distribution of the lesion. So the AI helped in the detection, yes, in the diagnosis, in the distribution, and in this time it guided my needle for the biopsy. الفيلم العربي المرة دي جايباه هو عمارة يعقوبيان، وليه جايباه علشان خاطر فكرة ال AI with the calcification. The point is that in the AI هو detected the calcification دايما، هو فعلا حقيقي له sensitivity عالية جدا in the detection of the calcification. But what about the diagnosis? Actually in the movie نور الشريف كان عايز يترشح للانتخابات، وكان عايز ياخد دايرة قصر النيل، وكان شاكك ان هو يكسبها. فساعتها خالد الصاوي كان رئيس الوزراء، فقال له اللي عايز يترشح يترشح، لكن اللي عايز ينجح دي بقى لعبتنا احنا. Which actually this goes with the calcification and AI. AI detects whatever he wants for the clustered and the grouped calcification, but when gets to the diagnosis, it's our job. احنا اللي هنقول مين اللي benign ومين اللي malignant، لكن at least he will detect, will decide the distribution of the calcification, the follow-up, and for the biopsy. احنا عملنا ريسيرش في بهية علشان نشوف الكالسيفيكيشن اي اي كويس ولا لا، ولقينا ان السنسيتيفيتي بتاعت الاي اي يعني مور اور ليس احسن من السنسيتيفيتي بتاعتنا في الديتكشن اوف ذا كالسيفيكيشن، بس السبيسيفيستي بتاعتنا احنا معدياه في ان احنا نقول بناين ومالجننت، لانه ساعات بيلاقي بناين كالسيفيكيشن ويديها هاي سكورينج، لان اكشولي الالجوريزم بيبقى فاد مش in the form of morphology, heterogeneity, speculation, increased density زي البارادز بتاعنا circumscribe and distinct. No, it's fed with images. Cancer not cancer, cancer not cancer, and if it's not fed with this type of cancer هيحسب ان هو negative although it's a cancer. But for us we goes with the morphology descriptors and build them over each other, and that's why sometimes we consider the lesion Barrett's 4 for only one descriptor, although all the other descriptors goes with the benign morphology. And sometimes when I'm having a cancer, give me an 11% for the same reason, at this case, which was case number 11. For the AI, when he sees these two images, he will not be able to differentiate between the street cat and the house cat when you find the house cat in the street. But for the radiologist, I know that this is a house cat in the street, but this is a street cat in the house. For the screening mammogram, a comparison should be made with barrier studies to establish the benignity through the long-term stability for at least 2 years for the calcification, if the calcification present in the screening mammogram. If the calcification present in the diagnostic mammograms, we need to view a magnification views should be performed to confirm the morphology and the number of calcification. The ultrasound for the suspicious calcification, I'll do a focus ultrasound targeting this area of cluster calcification to evaluate if I'm having an occult mammography such as a mass, coinciding with the cluster calcification. And of course, the short interval follow-up, where an isolated group of punctate calcification required a close interval with the mammogram after with one side with a view for the MCC and MLO for the calcification, if mammography is appropriate. Thank you. Any questions? بصي I need a microphone مثلا.
Well, some of the cases of fibrocystic change, I could not understand why you predicted that this will be a fibrocystic change or benign calcification. Like case 5, could you please just...
The calcification or to detect it's a malignant, I need to have to be coapted to each other, clustered in the same 1 cubic centimeter. You have a more than 5 calcification clustered with different shapes, different sizes, and coapted together. And when I images in the CC and MLO view, it needs to have the same distribution. When it's linear, it goes linear. When it is regional, it stays regional. When it's segmental, it stays segmental. But for the benign calcification, I'm having spaced fat components between the calcium.
Yes.
The calcium have the same sizes, which goes mainly for the punctate calcification. Yes. And when you do the MLO from the CC, you'll find the calcification after have taken a linear orientation. In the MLO, it takes a vertical orientation because it's in the cysts, it's in the secretions, it's not in a soft tissue. But if I'm having the calcification in a soft tissue, it will be targeted along a sheet. The distribution will be stable in the CC and MLO. There will be no intervening fat, and moreover, the more confirmation goes with the different sizes and different shapes,
Yes.
and also put in your mind the family history of the patient and the age of the patient, hormonal status.
Okay, thank you.
Okay, I guess this is all. Okay, thank you.